presentation.
Okay, thank you, Fan, for the introduction, and also all the organizers for the this kind invitation. I'm very happy. It's my first time to speak in Indonesia, even though it's on the web. Okay, so I'll share my screen. Just a second. Okay. Here we go. So in the next 30 minutes, maybe if I go over time, please stop me, please, because I've prepared quite an amount of slides. I see about over 100 participants joining. I hope this will be something that you can put into practice in your daily, angiographic analysis and everything. I've shared some of my slides, mostly the illustrations, through the organizers. If you haven't got anything from them, you can ask them again. I would be happy to share my slide. You can record my talk or anything of that sort. I have deleted all the patient's information, so it should be fine. I don't have any disclosures concerning this topic. Okay, so it's going to be like, so you see the external carotid artery. Actually, it's a very vast system to talk about in a short period of time. So if you will allow me again, maybe I can give a part 2, part 3, part 4, up to part 5 maybe. Okay, so you see an injection of this external carotid artery. I would like to know how many vessels you can name, or sometimes you have to be able to predict something that you cannot see actually on the pictures. Some connections that you have to be able to predict precisely based on your anatomy knowledge. And you have to know which vessel you have to be very careful about when you're trying to embolize, occlude something. Okay, so I put a lot of things here. So actually, embryology helps you a lot to understand the basic of the anatomy, the variations and everything. But it's going to be a little bit difficult to swallow at first. It's not easy. It's not an easy subject. So I just give you a little bit of introduction of embryology, just a little bit. The other one would be more on the clinical, the angios and the practical side of this story. Okay, so these are the branches of the external carotid artery system. Probably any fellows, any residents will have probably mastered all the branches here. But this is just an illustration. It would be very nice if you can name all the names, pick out all the vessels from a single angiogram. That would be an ideal thing to do. So it's kind of like it's actually a complicated system than the system of the internal carotid artery. Because it has to go to many territories. Okay, something deep, something more superficial. So sometimes if you look at this system with the bone, I will show you more pictures of this. It would help you a lot better to understand the nature of the vessels. For example, if you see the middle meningeal artery, you will sure it has to enter the skull through the foramen spinosum. And to reach the nasal septum and the nasal concave, the artery has to go through this sphenopalatine foramen and so on. Okay, so the foramina, the openings of the skull, is very important for you to have something as a background to understand all the branches that enter the skull. This is more of like the skull-based arterial anatomy. It's not totally related to the external carotid artery system, but these are the vessels that we have to be very careful about, because it's not just the soft tissue. Sometimes it has the connections to the brain arteries. So those are the important things that you need to know. So the openings and the nerves, you probably have learned this since medical school, so it's not a big deal. But once you become an interventionist, endovascular, neuroendovascular interventionist, you have to know all the vessels or the exceptions in some of the cases, which vessels go through which channel to be able to interpret the images correctly. Okay, you put into a chart like this, it's a little bit, well, maybe easier to memorize, but to put into practice, you have to be able to read the images. So there's a lot of information in here, but these are the vessels that people usually go into and try to do something like embolize, okay, like maybe the middle meningeal artery. So we will focus on some of these important vessels. Okay, so we see the external carotid artery system as a single trunk, but actually it's composed with different, compartments, like the system of the internal and maxillary artery. There's a system of the ascending pharyngeal artery in the middle of the skull, and posteriorly you have the occipital artery. Not something that difficult, and just a little bit of this basic plans for the nervous system arteries structure. At the spinal cord, you have the central nervous system as the spinal cord. You have the peripheral nervous system as these peripheral nerves, and along the nerves you get one artery per nerve that goes in intradurally to create this neuroaxis arterial system, which usually we call this anterospinal artery. So we have a link between intradural and the blood source, which is here, is the dorsal aorta that is linked with the nerve root. The same thing happens actually in the head area too, but it's the transformation that happened during development of the head, of the brain and everything is so tremendous that it makes the structure so complicated. But I just want you to remember the golden rule that if you have a nerve, usually I have an artery that runs with it. One from the intradural artery, the other one from extradural. So this is the basic plan that you need to know when you try to understand everything. And the development of the internal carotid artery compared to the external carotid artery, you have different territories that the vessels need to supply. But these territories will join, or we can call it, they will annex, and they will change the territories. Some branches will go away, regress, to make something like different shape than it was at the embryological stage. But sometimes there's some, problems in development. So we have some of the remnants of the branches that was there during fetal period. So this is something that's a little bit complicated to listen to. Just give you a little bit of hint of just the vessels are not just pipes that is just built on a single plan. It goes through changes during life that makes things complex, but at the same time, it makes you understand the anatomy. That anatomy will make more sense if you understand embryology. We don't have time to go over that completely. I will go very briefly for the arteries of the face and the facial area. So we have the arteries that goes into the facial area. It's a facial artery. You have the transverse facial artery. You have this is called the zygomatico orbital artery. It runs above the zygoma, goes around the orbit. They do anastomose. And these arteries, when you have a cut in the face, usually the wound will heal very well because there's a lot of supply to it, and it has a good anastomosis also to the opposite side of the face. So this is a patient with like a large hemangioma of the face. So you have this kind of things, but these are not only superficial arteries. Some of them, like the top two ones, the superficial temporal artery or the zygomatico orbital artery around here, they will have some connections to the ophthalmic artery, which you have to be very careful about. Okay, so such as in this case, you can see the internal carotid artery being filled retrogradely by this filling of the ophthalmic artery, which is filled by this superficial temporal artery, or some even from the lower down from the vessel of the face. So this one is filled from another collateral from the lateral side of the orbit. We'll talk about that later. Okay, and to supply to the scalp, this is not very difficult. There's mainly 3 vessels that go to the skin here, but it's important to know that well, I've told you that the superficial temporal artery can connect to the ophthalmic artery, so there's some risk that you can penetrate your materials into the ophthalmic artery. And these 2 vessels, the posterior auricular artery is a very small vessel over here, arising a little bit proximal to the STA, and also the occipital artery, which is mainly goes mainly to the skin. It also participates in the cranial nerve supply, which is very important to recognize. Okay, so the supply to the skin is not a big deal. So we have like these 3 vessels, but one vessel is larger, the other one will be smaller. Like this one is like we have a very prominent posterior auricular artery here. So we have a little bit smaller occipital artery, a little bit slightly smaller, and we don't have the parietal branch of the superficial temporal artery, like in this case. So it's like it's in hemodynamic balance between these arteries. Arterial supply in nasal cavity, sometimes you need to stop the nosebleed as you go into this sphenopalatine artery. You see the branches that go to the lateral side and also the midline to feed the septum. This runs through the sphenopalatine foramen. When you look at the AP view, it's like you see the whole length of the whole the vessel very well. But when you look on the lateral side, it's like you're not having a good view of the whole length of the vessel. So you have to decide which angle to use when you want to do something to the vessel. Okay, so this is the thing. We can see it in the same thing in 3D. The 3D always helps you to understand things in 3 dimension because we usually use the DSA on 2D, which is very convenient way to get information, but sometimes you need to study the 3D too. And once you get the pictures in 3D and have the 3-dimensional image in your mind, then you look at the 2D again and you can see which one is deeper, which one is more superficial without looking back at the 3D. So these are the other anastomoses. So the external carotid artery system has a rich anastomosis. They have a lesion over here. If you embolize from proximal part, you won't do anything to it. You will make the treatment more difficult in the future. So anything you need to do, you have to go to the lesion itself to block everything. Like this, you have even the collateral through the lingual artery, the collateral through the superior thyroid artery when the contralateral side of the external carotid artery is occluded. So you get anastomosis everywhere. Okay, so again, go back here. Looks like a 2D, it's a 3D, but I put this in color. So you see different systems of mainly the system of internal maxillary artery. So this is the system of internal maxillary artery. You have different branches. Some you can tell, some I'm not sure if you can differentiate all the vessels. You have smaller vessels, but let's look at this in another way, okay? 3D helps, but still, if you have the bone with it, it will tell you the difference. So you have this one, you have a lot of information, but you put the bone back. It's a very good landmark to see which vessel belong to which compartment. Like this, so we have cut the superficial temporal artery. So we see here, this is the middle deep temporal artery. This is the anterior deep temporal artery in like pink or red. So this is the infraorbital artery, which emerges from the hole over here in the face, becomes the artery of the skin. And inside, we have here the middle meningeal artery. So this one, of course, it goes inside the skull. So we know where it goes into the skull, but we can see this on 3D too, like this. When you rotate this, you can stop here. You can see that the vessel is entering right here at the foramen spinosum, which is just lateral and a little bit posterior to the foramen ovale over here. Okay, so this is how you interpret your pictures and read the images. Okay, so we will focus on some of the branches of this internal maxillary artery. So these are the two components of this one. The middle meningeal artery is a very prominent, branch of this internal maxillary artery. It arises from the proximal part of the internal maxillary artery. It goes through the foramen spinosum and supply literally the whole system of the dura mater of the cranial vault. Also, it has connection to the orbit. You can see this is a vessel inside the orbit. It has also the connection to the posterior fossa. You might think the middle meningeal artery only supply the superior tentorial area. No, it's not. It supplies the tentorium too, and also has connection all the way down to the posterior fossa. So it's a very major supply to the dural system. Okay, so you can see everything here. So I put this into an illustration. Illustrations, if you write it from like anterior posterior view, lateral view, you don't get a lot of information. Actually, from oblique view, something like this is something I learned from my mentor, Pierre Lajeunesse. He always draws in like in oblique views. So you get twice the information. You can see both sides. You can observe the structures a little bit in a three-dimensional perceptive way. So again, we see the middle meningeal artery arising from the entering the skull from the foramen spinosum, going to the cranial vault. But that's not all. It goes all the way here and runs parallel to the sinus and join here at the cribriform plate to join the ethmoidal artery from the ophthalmic artery. So you have another connection here to the ophthalmic arteries, which is you have to, it's very far from that, but you have to also recognize that one too. The other major connections, you can have a branch that goes through the superior orbital fissure over here, which is, it will go to join the ophthalmic artery system. So anything you put in here can enter the ophthalmic artery and cause problems with the visual function. It has also the supply to the tentorium and also posteriorly to the falx. So almost everywhere. Also, very important to notice, it has connection to the internal carotid artery over here too, although it's a little bit quite small. Okay, I think I shouldn't spend time a lot for this, but just to let you know that the development of this external carotid artery system and the internal carotid artery system is not like separately developed. They were connected together at one stage. They got separated, they get disconnected. So there's a lot of changes in the territory that make it a little bit more, seem a little bit more complex. One place that it gets connected is around the orbital area or the ophthalmic artery. The other place is around this near the cavernous sinus or the middle ear space. So this connection that this has, there's a remnant of this connection that usually it goes away. This one, it doesn't go away. So you have an middle meningeal artery arising actually from the internal carotid artery at this segment over here. So it's a strange looking vessel, but it's just a remnant of the embryological state. And also, this is this one is extremely rare. So usually you don't run into any kind of case like this, but look at this case, okay? So we're injecting into the external carotid artery, mainly the distal part of the external carotid artery. And what do you see? Anything strange? Anything you need to notice? So it's here. So this is you can see the choroidal blush here. So you have the vessels of the eye in this injection. So why is that? Because there's a lot of connections between the middle meningeal artery and the ophthalmic artery. So if you miss this, you inject particles, everything, you can interrupt in that ophthalmic artery. Okay, so again, we go back, look at the system. Every time you look at the middle meningeal artery, try to look back at this illustration, try to match everything, which one goes here and there. Try to think of the vessels that you don't see on the angiogram, because it might be there when the injection is perfect. You can see something. Once it's not really perfect, sometimes you miss something, but it's there. Okay, so the connections to the ophthalmic artery is very important to know when you do things with your MMA. Okay, so in this case, you see a very small ophthalmic artery coming out from the usual site of the ICA, but on the external carotid artery injection, you see another set of the ophthalmic artery. Okay, so this in this picture, in this patient, the patient had two origins of the ophthalmic artery. So they derive from different embryological origins. We haven't talked in detail about that, but anyway, they have a very high affinity, the MMA and the ophthalmic artery, through the superior orbital fissure. So you can put in a like illustration like this. There's always, not always, sometimes a connection like that. You have to know the potential that it can be connected. Okay, so just this is another case. Just think of the connection of the MMA and the ophthalmic artery. Okay, so there's a meningioma over here. We expect to see a tumor stain. Sometimes you don't see, but in this case, we expect to see a tumor stain here. So we injected the external carotid artery, but we don't see it. Why is that? We have the MMA. We have the MMA here. Okay, but we don't see it. We're missing something. We don't have the dural branches in the frontal part. So why is that? So you have to look again. It's the opposite of the last case. Now the ophthalmic artery is using the same connection to supply the dura. Okay, so in this case, you have the middle meningeal artery frontal branch coming out from the ophthalmic artery through this connection. So it can be in a way or vice versa. Okay, so put it in 3D. You can see this dural branch coming out of the ophthalmic artery. Superiorly, when you see it, this is the ophthalmic artery. Again, through the lateral side of the superior orbital fissure, you see the middle meningeal artery coming out over here to supply the tumor. So you have to think in like putting pieces together. Okay, so the connections to the ophthalmic artery is a very have a bunch of pictures to show, but anyway, just think that anything that goes near the orbit will have a kind of like potential anastomosis to the system. But for the MMA, it has this embryological, background that is very, very highly related to the ophthalmic artery. The other arteries connected from the external carotid artery system. Anything around the face, you can see that. You can say that superficial temporal artery, facial artery, deep temporal artery. This one will go through the bone. It's not just under the skin, and the ones from the opposite side also through the bone, through the face, and many paths to go. Why is that? It's a surprise. It gets a very high supply from everywhere. Maybe it's because of this. Look at the bone. This is a bone of like a monkey or a gibbon. Okay, it's like more like human. We have the whole surrounding of the bone for the orbit. But this is the skull of the dog. You can see we have the inner wall, but we're lacking the outer wall. So over here, outside of the orbit, you have the vessels can connect quite freely. So anything you see around here, even the vessel of the scalp or the muscle, as the deep temporal artery is, it will have the potential connect inside to the vessels inside the orbit. Okay, let's move on to the next one. We're trying to, we need to speed up a little bit. This is another important point to see. Around the cavernous sinus, we have the branches of the middle meningeal artery, and the other branch we can see here, which is, I haven't mentioned about this vessel before. If we were doing this in like real conference, I would have asked you to rest your hands trying to answer this. So let's imagine you're trying to answer the name of the vessels. Okay, number one, what is it? It's the occipital artery. Number two, so this is the superficial temporal artery. It's smaller than the MMA because this MMA probably has something up here. I don't know. So this is the MMA. Okay, number four, what it is? It's like in this angle, so it's the sphenopalatine artery branches. And so what's number five here? It's not, it's a little bit anterior to the middle meningeal artery. It connects to some weird looking vessel over here. So this is the accessory meningeal artery. It's not a big supply of the dura matter, actually. In contrast to its name, it actually supplies the soft tissue mostly, and has a connection to something over here. So we see a very strange looking like S-shaped vessel over here. We see the same thing on the ICA injection. So we put these two side by side, and you can see that this is a a very large connection that we can have from the accessory meningeal artery, a little bit from the middle meningeal artery through this channel. And you can see a faint opacification of this internal carotid artery from this external carotid artery injection, which shows that there's absolutely, obviously, a connection over there. So this is the vessel that we call the inferolateral trunk, which is a connection between these two systems, which is very important to recognize. So in the same thing in the illustration again, this is the accessory meningeal artery. Sometimes it arises as a common trunk with the middle meningeal artery. Sometimes it arises separately, a little bit distally from the middle meningeal artery. So this is the network that you need to, the MMA, ophthalmic artery, the accessory MMA to the ICA, there's the link over there, okay? So this is the system that you need to know. The same thing in different angle, superior view and lateral view, all the same thing. So there are vessels. Why are vessels trying to enter the skull? Why is that? Because as you've seen in the first slide, there's a nerve there, the fifth nerve. Once you have a nerve, you have the vessel that's going with it, one intradural, one extradural. So you have the link that runs with the nerve. So this is the logic behind the story, okay? So a little bit more, there's a lot of spaces over here, a lot of little foramina over here. Again, the same thing, a little bit oblique. So this is the foramen ovale. So this is accessory, middle meningeal, connected. This one it can go to the ILT, it can go also to the meningeal hypophyseal trunk with the same logic. So we have a lot of connections over here, okay? So just remember this middle meningeal artery, accessory meningeal artery, and some of the branches of the sphenopalatine branches for artery of the foramen rotundum can have the potential to connect to the internal carotid artery along the nerve. So we move a little bit backwards, okay? At the back of the head, we have the occipital artery, okay? I have skipped the anterior ascending pharyngeal artery. We will talk about that at the end of the talk, okay? So this is a branch that you can recognize very easily because it's quite large. It's a distinctive look because it runs at the back of the head. So you need to know about the origin, the branches again, and anastomosis. This is a strange looking occipital artery because it arises from the ICA. It's quite rare, but sometimes you see this. So that's another possibility of the origin of the occipital artery. Usually it arises from the proximal part of the, it should be ECA, not ICA, okay? And sometimes it shares common trunk with the ascending pharyngeal artery, okay? Sometimes, not frequently, it arises from the ICA itself. So there are segments that people give names to this occipital artery. The ascending segment, you have the horizontal segment, and it will ascend again. So it's 1, 2, and 3. Why is it important to name these things? Because we have branches coming out up there, especially like segment number 1 and segment number 2. We have a lot of branches that is very important for you to know. So we go to name the branches. There's the mastoid, the jugular branch, stylomastoid artery, and the maxillary branch. There's a lot more branches with names, but these are probably the names that interventionists need to be able to recognize and know where the dangers are. Okay, so in angio, no big deal. You see something like this, segment 1, 2, 3. Okay, so just to remind you again, the occipital artery is not only the artery of the scalp, but it's actually, it gives the mastoid branch, which becomes the dural, you can call it meningeal branch. And you have the neural branches, which feeds the nerve and the central nervous system. Part of it can have the connection to join the intradural arteries that feeds the neural system. It's the jugular branch and the stylomastoid branches that they just enter the foramina with the same name. Okay, so we'll look at them in a little bit more detail. So the mastoid branch, okay, it's usually from the, it's not usually, it's from the second segment or the horizontal portion of the thing. It goes through the mastoid foramen, the emissary foramen. So it has this particular looking thing that it turns here. So this is the foramina that it has to turn to enter the scalp and goes inside the dura. So it looks something like this. So this one is feeding a dural arteriovenous fistula. Okay. Another one here, the same thing, horizontal portion, turn anteriorly, enter the skull, and becomes a dura branch. A little bit more selective injection of the same patient. Okay, so where is the mastoid emissary foramen? It's here. You can see it here on the skull, or in the model. It's just at this the posterior aspect of the mastoid. Okay, even on MRA, you can see the signal of this artery. On 3D, the same thing again, outside the skull, passing through this foramen and entering the skull to become the artery of the dura mater of the posterior fossa. The same pictures, always another shunt. So this is where it turns and enter the skull. Always remember that. That's the point that you enter the skull and have the connection to all the dural branches of the other system. Again, okay, the same thing. Turn here, give superior trunk, the other inferior branch here, all going to the shunt. So it's just the same artery all over and over. It's quite easy to recognize. The jugular branch, this one is a little bit smaller to see in normal anatomy. Usually it supplies also the lower cranial nerve. This is not only a dural branch. It goes to become a dural branch later on, but it supplies the lower cranial nerve at the beginning. Okay, so this is very important to notice. So where is it? Okay, where is it? So this is an injection of a common carotid artery, but you can see something over here. So every time you see, like for the MMA, it has to go through the foramen spinosum. For the mastoid branch, it has to go through the mastoid emissary foramen. For this jugular branch, it has to go through the jugular foramen. So it has this, anterior posterior path, and it goes after that into the posterior fossa. So it has this looking particular shape that you can recognize always. This is another example. Okay, so this one you can see here, over here on the anterior posterior view. It's quite difficult to see, but at the end you see the dural branches of the posterior fossa over here from actually this artery. Okay, so it's the same thing. Yeah, so you only see the dural portions, but at the jugular foramen, actually, it is supplying the cranial nerves. Okay, so you can do embolization over here, but you have to be more careful when you do something over here. So that's the difference. Okay, again in 3D to help you get the three-dimensional concept of this thing. So this is the jugular foramen. Okay, you can see the artery coming to join the posterior fossa. Okay, here there are two branches, medial branch, lateral branch, and you can see it's arising from the occipital artery over here. Maybe it's turning too quick. Okay, I think you get the idea. Again, in a drawing, the same concept. Okay, so we have talked about this branch and this branch, and now we go to the muscular branch. What's the big deal with muscular branch? It's only the muscle? No, it's not only the muscle. It has a very important function that it can anastomose with the vertebral artery, okay, and also other arteries of the neck. So in this picture, you inject the occipital artery, you don't see anything. So this is like there's no connection. But in some of the cases, you see something like this. Okay, this is the zoom view. This is the occipital artery. Okay, so over here you see a turn here. It connects to something very faint here. Every time you see a small vessel being washed out of nowhere, usually vessels will become smaller and smaller and smaller. But this one is washed out, like the contrast washed out. So you must expect that that vessel is entering into another large vessel, and your contrast is being washed out. So you have to be careful that it will reach another system, which this one is the vertebral artery. If you inject particles in the occipital artery proximal to that, you will end up having a severe stroke for the patient. It can be the opposite, as you've seen with the ophthalmic artery and the MMA. One can come from the other can come from the other one. So this one, we will have the opposite picture. The occipital artery is arising from the vertebral artery. So it makes sense, it's just connection. So to understand this is actually, there are actually segment number 1, number 2, number 3, and arteries are actually originally connected through these segments. Later on, it becomes like another single pipe of vessel or everything, but actually it's still have, it can still have this potential anastomosis through these segments that we see. Number 1 here, number 2 here, it doesn't have any connection, but sometimes you have all the connections, 3 levels. So this is the explanation for the possibility for these vessels to connect. So anything you inject into the occipital artery, a little bit proximal over here, you might end up entering the vertebral artery. This one has 2 connections, okay? 1 and 2. So this happens. It's not a big surprise. You can also have the connection to the ascending pharyngeal artery over here. Okay, so we must remember this branch, usually it arises a little bit proximal from the mastoid artery. Anything distal to the mastoid branch, usually it's safe. It doesn't have any connection to the vertebral artery unless you reflux. If you reflux, you cannot be safe anymore, okay? So the last thing that I want to talk about is the ascending pharyngeal artery. Again, it's a very small vessel. It's a very small vessel. I wanted you to show me where if you know where the ascending pharyngeal artery is in this picture. It's number 6, okay? It's number 6. It's a very small vessel, but it is an extremely important vessel for the interventionist. Small vessels, okay? In neuro, small vessels really matter. Like the anterior carotid artery, it's very small, but you can get occlusion of internal carotid artery without no consequence. But occlusion of anterior carotid artery can be very devastating for the patient. Okay, so this is a very small artery. You might miss, you don't see it very well, but it has a lot of connections. I will not be able to talk about everything about the ascending pharyngeal artery with the limited time. I made this illustration trying to put into words all the connections, but I was so, it was so difficult to type all the connections, so I just made this in writings. That's just to tell you how much this anastomosis you can see in this system of ascending pharyngeal artery. So it's straight. It arises from the proximal part, a little bit distal from the occipital artery origin. It's quite straight, very small vessels over here. Branches, okay, branches. Sometimes it arises all together with the occipital artery. This is the occipital artery. It shares a common trunk with the occipital artery. So it's possible to have or another version of that. You can have the ascending pharyngeal artery arising directly from the internal carotid artery, as you've seen with the occipital artery. Okay, so branches. So we can divide this into like 2 major portions. You can have the arteries that mainly supply the soft tissue, but it's not really only the soft tissue. Actually, this will have dangerous connections to the internal carotid artery system also, and also the internal maxillary artery. As I've told you, it has a vast range of anastomosis. And the posterior one, okay, the posterior one, this one will be what we call neuromeningeal trunk. Neuro means it feeds the nerve, it feeds the brain. Meningeal means it becomes a dural branch. So it's probably the same as what we've seen in the branches of the occipital artery, okay? So there was a report of something like this in the literature. They embolized through this ascending pharyngeal artery and ended up with a patient with a large stroke in the posterior fossa like this. This is very sad. Huh? You don't want this to happen to your patient. Oh, it's a complication. It was unavoidable, but you have to be able to explain this by your anatomy. So why did this happen? Okay, you have seen this illustration before. Anything you inject here, there's a possibility to enter the vertebral artery. For the ascending pharyngeal system, through this neuromeningeal trunk, there's we call this odontoid arterial arch that connects this one to the vertebral artery. That anything you inject can enter the posterior fossa. So this is a selective injection of the ascending pharyngeal artery. What you can see here, there's a lot of information. You can see the sphenopalatine artery. Why? There's a connection here from the superior branch of the pharyngeal branch. You can see the vertebral artery here because of the connection here. And also, actually, you can see again a very small artery that goes here and suddenly stops. Anything that suddenly stops will tell you it enters another system. So where is this? This is at the posterior clinoid process. So this is actually the point that it joins the internal carotid artery system at the meningeal hypophyseal artery origin. Okay, so this is very dangerous. You inject anything, you can enter everywhere. Okay, I will skip this. It's a little bit. So the last message that I want to give you, this is very important. Another report, they injected a onyx into the middle meningeal artery to treat a dural arteriovenous fistula, and they ended up with a severe facial nerve palsy. So why is that? Okay, so you can see here the middle meningeal enters the skull here. At another angle, I give you this middle meningeal artery here again, foramen spinosum entering the skull, anterior branch, and you have learned that this will connect to the ophthalmic artery. And there's very small, tiny branch over here that runs along with the petrosal nerve, part of the facial nerve, to join the system. And this one will be joined. This is called the petrous branch of the middle meningeal artery. It looks like this on the lateral view. And there's another counterpart to this. It's called the styloid mastoid artery, which is usually a branch of the posterior auricular artery. And it also arises sometimes from the occipital artery. So you have like an arcade that feeds the nerve like this. This one can arise from the occipital artery. Has the connection also to the internal carotid artery. And also there's another branch, as I've told you, there's one intradural, there's one extradural when you have a nerve. So in this one, you have the ICA also supplying this one. So anything you inject around this area can enter everything around the facial nerve. And if you're more unlucky, you get very, very unlucky, you might enter also the ICA territory to get a stroke. So this is the facial arcade, this is styloid mastoid artery. It's a very small artery, very, very difficult to see on the 2D DSA. We have the thick bone here of the mastoid bone, and you have the petrous branch here, very small also, to form an arcade. Usually you don't see it, but you have to be careful when you trying to do anything along the skull base at this point of the MMA or at this point of the posterior auricular artery. Okay, so this is what happened in that case. They injected the onyx. It enters all the way to this the supply to the facial nerve. Okay, So last thing, last case for you to like practice something, put something more in the practical side. Okay, so this is injection of external carotid artery trying to embolize this meningioma. Okay, no big deal. You see a large middle meningeal artery. Okay, here, large middle meningeal. There's a branch from the STA here too. Okay, so after listening to this lecture, you might say, oh, you have to be careful of the ophthalmic artery, but you don't see anything. It's usually around here, superior orbital fissure, remember? So it's usually around here, but you don't see anything. So you think it's safe to embolize? Yes, I think it's safe to embolize. So this is the other side, okay? But so this is more selective injection, a very good injection, but still you don't see anything connected to the ophthalmic artery, okay? So it looks safe enough. Okay, so we embolize, and after that, we do another injection. Look at this. Okay, you don't see it in every frame, but here. So this is actually the artery that is entering the orbit. It might have some connection to the ophthalmic artery. I'm not absolutely sure, but there's a potential that you can do harm to the ophthalmic artery through this channel. I will play this again. It doesn't show it on every frame. You have to have your catheter over there, a little bit pressure injection, just to opacify this one. It wasn't shown at the previous picture. So sometimes you don't see every connection, okay? But you have to be able to predict where they are to have your catheter at the best position, use the materials you think it's safe according to anatomy that you learn, okay? So you recall this one, even though you see this picture, you know where to be careful about. So that's what anatomy is for. Okay, so once you look at, so this is the final picture that I want to show you. Again, the same questions. After this lecture, probably you're seeing more information in this angio more than at the beginning of the lecture. Okay, and I would like to express my my thanks to this great teacher, Professor Pierre Lejeunesse. He wrote this book of surgical neuroangiography, packed with a lot of anatomical information. You can read this for 10 years and you can still probably not be able to understand everything he says. But he left us a very good message. He passed away, unfortunately, in 2008. He said anatomy is the message between the specialist and the morphology of the patient, like a language. Okay, so if you don't know the language, you will not be able to communicate with the other person, as if you won't be able to interpret the morphology of the disease of the patient itself. So as a language, you cannot learn like you just cannot learn Japanese in 3 days. It needs to be practiced. You have to repeat over and over and over. So that's what you should do in anatomy. So I've left you some illustrations. You could use that, compare it to your angiograms, and practice over and over again. Okay, I've went over time. Sorry for that. Thank you very much. This is my last slide.
Thank you very much, Dr. Kitipong. It's a very awesome presentation. It's a cover basic to the clinical finding. So for the attendee, if there's a question you can ask directly, you can type directly in the QA box. But since we have a guest that really need to have another meeting, so maybe we can give the screen to Professor Azmi before he have a very short time. Professor Azmi, maybe you can share the screen.
Yeah, I'll share my screen already.
Okay. After this, we'll go to the discussion.
You discuss start now.
Now is your time, Dr. Azmi.
How long yours is total time left, roughly?
Yes, I think we have a 1.5 and 2 hours webinar. So
okay.
10 minutes enough for sharing case.
Okay. Actually, thank you very much. This very excellent lecture from Dr. Kitipong. I prepare more cases rather than basic anatomy because Dr. Kitipong overview of anatomy, extracranial anastomosis, and also anatomy, and it's very excellent. So I will go, and also we can see how we interpret the basic anatomy to tackle the disease. And also Dr. Kiripong also can help us how to tackle the disease that we already see during the procedure. Okay, this is the basic anatomy already explained well, illustrated well by Dr. Kiripong just now. But as we know, transactional embolization of extracardiac artery has major role, not only in epistaxis, also in the treatment of dural fistula and also pre-embolization of base scalp tumor. It's very crucial to understand the possible anastomosis that to prevent complication and also reduce morbidity and mortality during the procedure. There's three regions along the skull base constitute potential anastomotic routes between extracranial and intracranial arteries is at the orbital region, retrocavernous, and also the upper cervical region. This is very good illustration in the paper that shows that this is the most area that we have pay attention when doing any treatment and also embolization for the patient during the procedure. There's the region, it goes to the tertiary orbital region via the ophthalmic artery that is interface between internal maxillary and internal carotid arteries. The petrocavernous region via the lateral trunk, petral branch of internal carotid artery, and also meningeal trunk to the carotid artery. And this is also very important just now, is upper cervical region via the ascending occipital and the ascending and the cervical artery of the vertebral artery that we've seen the last slide from Dr. Kiripong. Why this anastomosis is very difficult to see? There's a few reasons. Just remember that you see that Dr. Kiripong embolized the slide embolization of the meningeal just now. They appear under these following circumstances. Okay, when this increase intraocular pressure, when we already embolize the tumor, then the anastomosis can become appear, especially when you're doing procedure like supersteric injection. And also there's a presence of high flow shunt as a consequence of the side effect of this procedure. And also when we occlude the vessel, there's a lot of carotid root occurs during, will open up during the treatment. This is a summary, it's very busy slide of the anastomosis. I will cancel the slide you later. And also, as I mentioned just now, how the ophthalmic artery have branched from with the meningeal, internal maxillary, supratemporal artery that have potential disaster if you're not very careful with the treatment. Not only supplying the blood vessel, they're also supplying the cranial nerve. This is very important because even though we do a lot of measures to prevent the complication, but the characteristic of the material that benefit sometimes is beyond our control. It's very important when we want to do decision for treatment to tell the patient every possible complication, not only bleeding, but also possible cranial palsy following the treatment. So when we want to do treatment, we have to understand the indication, contraindication, understand anatomy, strategy, and also teamwork. And also we must familiar what material you want to use, the ambient agent like coil, liquid, particle, and sometimes maybe detachable coil. In most of skull-based dural malformation, we can treat with liquid. We have glue. We have, so this is the particle for pre-embolization. Sometimes blood shunt, we can use balloon. And for the principle for embolization of you look at material, we must understand what is the nidus. We have to understand how to play with reflux to get the good plugging and obliteration of draining wheel and understanding the complex anatomy of the lesion. And also we have in the market, we have histoacryl. When we're dealing with high fast flow muscular malformation, we have failed also new embolic material iodine based, but they tend to could have fragmented, and this mode occlusion like histoacryl, whereas for ethylene alcohol like squid and fish, squid, they more to layering effect. So we have to understand the behavior and of this material, and maybe we can use in combination to get the optimum result too. This is how the interaction with when the contact to the blood. Okay, again, we feel this more like occlusion, whereas that we call it layering to the vessel wall. This is also important in the decision making. This is how when it comes to the saline, it's like brittle. And also when we dealing with a complex treatment, we must also must be very creative in treatment plan. We have various ways to prevent complication. We can have balloon assisted also to prevent patency of the sinuses, and to get good penetration, especially for vascular malformation, we also need to form glute plugging in order to get the material go forward. And this also we must master the principle too. So this is the what we have in the market now: tail, onyx, squid, and the CDA. So let's go to the practical case, which already shown by Dr. Kitipong. So this is patient having what you call that, this pituitary surgery. After surgery, they have asphyxis. So this is you can see the intermedullary, they have pseudoaneurysm. This is a very basic. When we want to inject, we go as distal possible. Do run, make sure there's no any there is anastomosis that we mentioned just now. Then you can just inject with glue or coil in this case. Post embolization, there's no more treatment. I want to show how complication can happen when we dealing with this kind of tumor, especially like the juvenile angiofibroma. If there is no ophthalmic artery, this radiograph, we can see there's a lot of possible anastomosis. Like in this case, this is a boy 17 years boy with pre-op juvenile angiofibroma. We don't see ophthalmic artery in this radiograph. So when you don't see any ophthalmic artery in the scalp, you don't see colorectal blush, you must be very careful when you do the external carotid artery to look whether there is any possible meningo-ophthalmic branch. Even though we wish very far catheter distal into intermedullary to obliterate the pre-op embolization. So you can see this is the meningo-ophthalmic branch. This is meningo-ophthalmic branch from external carotid artery. Okay. We completely or almost devascularize the tumor. There's a possibility that the material that inject, this is we use particle Embogol, is more compressible. That this Embogol compressible, they can penetrate the vessel when we inject the open up collateral. Maybe it's because there's a lot of rich anastomosis, they can go to the ophthalmic artery, or maybe the injection is reflux. Then this is the disaster happen. You can see that material is causing central renal occlusion because maybe either reflux or the anastomosis that we don't see because the progressive injection and the collateral open up. Maybe also like the some effect that I mentioned, the three things, how can it happen? So in the future, if you see this kind of meningo-ophthalmic band, I advise not use particle, just maybe put the coil. Our principle just to reduce intraoperative bleeding rather than cure the treatment lesion. This is, you see the particle, and this can cause you medical legal complication. Okay, this very this I think happened when I just come back from fellowship. This is very important. Also, this patient referred from other hospital. They don't have any intervention radiologist. Maybe they just like it the ECA to prevent the bleed. After a few years, they come back again to us. You can see that's a collateral. This is like Prof. Kitipong, Dr. Kitipong mentioned just now. This is a ligation of the ECA, but there is a good anastomosis to vertebral artery. This is muscular branches now. So this ECA, like the ICA, because it reach anastomosis, you can see that the occipital muscular branch communicate. This is very nice uh, showing us to how the anastomosis is very important in the treatment. So this kind of patient, we need to expose the artery, or maybe you can also have direct puncture to reach, or we do a direct puncture to complete the embolization before send for surgery. Yeah, this is direct puncture and pre-embolization. The next step is middle emergent artery. The artery is the commonly used vessel, our favorite vessel for most of the treatment, like dural fistula, is easy to access because in the dura embedded, so it can allow us to push our wire even the vessel is very tortuous compared to use like occipital, which in under the skin. So this is the case of carotid cavernous fistula type 4. You can see that sedimentary artery go to the cavernous sinus. It also have a lot of complex anatomy within the sinus. We try to do transvenous approach, we fail, but the only thing that we can see just now is the feeder from can go back. Sorry, can I share? Friend, how is like this? You are scared.
Oh,
Oh, sorry.
yes. I think
Oh.
your computer.
Sorry. This is the last. Sorry. Okay, you can see this is okay, this is accessory meningeal artery. Go to the cavernous sinus.
You haven't screened the.
Oh, haven't seen.
Yeah, we haven't seen your
Screen. Okay,
your,
share screen. Can see
yes,
now. Okay,
yes.
sorry. This is the accessory meningeal artery that communicate with the cavernous sinus. So we inject fill in this case. This is very dangerous actually to just inject this material without. I advise we must also protect the ICA with balloon if you want to use this procedure. This is how we inject fill into the cavernous sinus through the accessory meningeal artery. Usually we will use coil at least during the treatment, but I think we have failed to recognize the intrapetrosal, even failed to the supra-ophthalmic branch. So we inject fill into the cavernous sinus. Yeah, some people say they can cause nerve cranial palsy too, but this patient, luckily we don't have anything happen. Okay, this is before. This is how the fill gradually fill up the cavernous sinus. Actually, it's safe that we have to put balloon because they can. This material also can reflux, integrate, go to ICA, can cause stroke. So this is complete after treatment. This is how we can see the fill with less artifact within the cavernous sinus. Sometimes also the safest one may be used. The different patient and different case, so we have to different strategy. There's not always same answer to every case. That's the reason we need much to familiar the anatomy and also understand the behavior or the material we want to use. In this case, I protect the ICA, retrogradely enter the ophthalmic vein. Then also because this fistula is very small, then this is glue. Then I inject fill. This is how post treatment. The commonly we treat is like dural fistula, like in the transverse sinus, sigmoid, super sinus. This is how untreated dural sinus fistula. They come present with chronic venous hypertension in bleed. is because undiagnosed before we send to our hospital. This is very complex appearance. We have retrograde venous reflux. We need to treat the patient to reduce venous hypertension. Of course, they have like occipital and also medial meningeal. Since the medial meningeal is in the petrosquamous in the bone, we can navigate our catheter as distal possible. Then we inject, like in this case, the onyx. This complete the treatment. Again, also some patients with fistula not treated, they have like venous hypertension, edema, they can have epilepsy. Again, even though the vessel is small, you can see the occipital branch is big, but because the occipital branch is within the subcutaneous tissue, we usually cannot reach the distal part of the as distal as possible. So we can just always inject. This material can penetrate well, but we have to control, carefully understand so that it doesn't go into area that we don't want to embolize. Okay, this cover. This is a latest case that I have done. This 37 years present with headache. They have tentorial branch. You can see this very, this like this is like Dr. Kitipong is now dural branch. They have dural, tentorial. Again, we go for tentorial. And as you can see here, there is direct communication between this fistula to the chamber sinus. So we need also to protect the sinus to prevent material coming back to go to the lung and occlude the fistula. And even we inject from this segment, we try to push as far as possible the material. And during this process, as you can see that Dr. Kitipong said, that material also can penetrate to the neural nerve and can cause cranial nerve palsy like facial nerve, maybe vertigo, cranial nerve palsy also can happen. In this, for this case, we use carbonate balloon to prevent this material from occluding the sinus, and also during injection, we can see some material escape into the lung. So we have to inflate, deflate during the procedure. So after the treatment, patient having complaint of vertigo, so we perform MRI to make sure that there is no impact to the posterior circulation. This is before treatment. You can see this tentorial branch from ICA. This is after treatment. There is a lot of feeders from with the meningeal branches now. This is only operated by, we use combination of squid 18 for first injection plugging and followed by squid 12 for further penetration. So this is the fistula point. It's completely obliterated. There's no infarct also, and the patient recover and discharge well after a few days. This is the fistula. This is an interesting case, dural fistula at the petrous apex. In CT scan, very complex, as large venous varix. So this is MRI. We have also have cortical venous reflux. There's like venous varix compressing the pons. So this is the angiogram. You can see this is the branch from the meningeal artery. And again, the principle is to occlude the fistula and also the place of draining vein. This is maybe the treatment plan and the vascular combination. So this is material that we can use. So again, you can see there's a lot of communication here. If you want to save, because of this is fistula, you can see a lot of small branch. Actually, it's safe to also put the balloon here during injection. This is how much we inject. I use fill this one, but as you can see, if you when you inject, then the field is continuously filling up and make the thing expand. We must completely obliterate the base of the draining vein. Even though we can achieve like this, they have like stagnation. It's not actually, in some cases we are safe, but this case is not safe. After a few hours, GCS drop and bleed. So I think we must really tackle close the fistula and also base on the vein to prevent this complication. This is very interesting cases that we saw of Dr. Kitipong just now, examining pharyngeal. There's a lot of see anastomosis here, and also anastomotic. I can share this slide with you with upper later. You have like anterior band and also posterior band, which more to neurovascular, and this pharyngeal band, and this is at the skull base. So, and they have like communication with the sinuses too. This lady present with acute scalp hemorrhage. When did angiogram, you can see this thing. Okay? This is jugular foramen magnum dural fistula that feeders from vertebral artery. So we only see vertebral artery, but when do angiogram, we can see this is from the from the posterior branch. Okay? This is the fistula. So the fistula communicate with will. The principle is the same. We must obliterate the base of draining vein to save the patient. Okay, this is multiple branch from the vertebral artery go to the draining vein. There's a lot of feeders. So also from here. At first, we try to embolize through extending pharyngeal as distal possible. I know this is the neuromuscular branch too, but if we go distal, if we manage to inject slowly, good plugging, and we can obliterate the fistula and also the base of draining vein. But I think in this case, we fail to get good good penetration. Maybe we advise really long by the window to use the more diluted squid. 12 squid is not very good. So you have no choice. You have to go from the vertebral branch here. Even though we have very good fistula identification of the draining vein and also base of draining vein, because there's very rich communication when doing injection with field. Again, in this case, if you want to inject from this feeder, it's very safe to put balloon here. To when even there is good penetration, but they also have reflux to the vertebral artery. So if this happens, you can see this. Even though the patient survived, but they got infarct, this embolization. This is characteristic of field because field is fragmented, whereas for active alcohol, onyx and field, there's more to layering. So you can fragment in multiple infarct. Again, the patient presented with SAH and parenchymal bleed. Okay, you can see there's feeders from vertebral artery, but nicely seen here from also from ascending pharyngeal artery. So we're dealing with foramen magnum skull base and dural fistula. They must usually they have like ascending pharyngeal. We always don't see, but this small vessel is very good in the treatment. So selective injection, but because this patient also have a pseudo aneurysm around this year, that next time when we inject, we have to inject very gentle, don't very forceful, because when I do selective injection here with forceful hand injection, they have like hemorrhage, escape of the contrast. Again, we use super selective injection. In this case, because we are already near to the fistula, we decided to use glue to occlude. This is complete patient recovered after the treatment. This also interesting case, dural fistula arterial condylar. They have feeders also from, this is from Occipital and also ascending pharyngeal. It's very dangerous to inject the liquid material here, and also you can see the retrograde reflux to the inferior petrosal sinus and also the ophthalmic vein, so that there's the reason patient present with proptosis. So this is the anterior condylar confluence of the patient. Is very detailed here. But in this case, we have to, we can use coil to treat this patient, understand this intercondylar confluence, and also put the stent into the infrapretal sinus to prevent the retrograde reflux. So this is how we treat patient with enterocondylar dural fistula presented with proptosis. This is another case. This is how a dural fistula can happen in this area. Sometimes there is a good, let's say, good communication between this ascending pharyngeal. This patient present with a cord myelopathy rather than bleed. You can see this is fistula. The MRI shows the dilated vein cerebellum. Angiogram. We also have figures from vertebral. So again, we go here, inject as distal as possible. This is the ascending pharyngeal branch. So this is after embolization, the fistula disappear, and also the cervical myelopathy is reduced after treatment. So in conclusion, the transarterial embolization of the scalp is very important. It's very important for us to understand the anatomy and also the possible anastomosis happen within the system. And also we must also very creative in choosing the material that we want to use for the treatment and the technique to get optimized result. And the anatomy is very important. It's the cheapest way and the very safe way to treat the patient if you understand well. Thank you very much. Thank you, that's all my lecture.
Thank you very much, Professor Azmi. Maybe if you need to leave early, I think. Because you have a very close, very tight
schedule. Got another half an hour to get another one.
Okay. Now, maybe you can unshare your screen, and maybe I will ask first for the panelists. Maybe from the panelists, is there any question regarding Kitipong presentation? It had covered all the basic and neuroanatomies, and Professor Azmi presentation about more the clinical. I think all the panelists have cases they can ask. Okay, maybe you can unmute your own Zoom.
Thank you, Dr. Afan. Can I ask for the question?
Of course,
okay, I have a question, but before I ask, thank you very much for the excellent presentation for Professor Kitipong and also Professor Azmi that have a lot of cases. My question is for Professor Kitipong. I'm just wondering about the venous, venous variation. Do the variation also happen in the venous, like as your presentation, many variation from arterial, external or internal? Is also happen in venous dryness or only in arterial? And if it is happen, what is the consequence of the treating of the AV malformation? Because the latest issue is we also approach for from the venous part of the AV malformation. Thank you.
Okay, so your question, thank you for your question. You're talking about more of the brain veins, okay? So the variations, of course, our veins, I think they have even more variations than in the arteries, and some quite still not really possible to explain embryologically. Why is that? Because the veins haven't been an object of interest. It's not really for like dural arteriovenous fistula treatment, as Professor Azmi has shown very beautifully. You only have to enter the foot of the vein. You don't have to understand the whole system. So there has been very few studies concerning the venous system compared to the arterial system. Especially for concerning the development and embryology. So we have a lot of things that we still don't understand completely. Some venous anatomy is still under recognized. We have published something recently, like a venous channel in the dural matter, very under recognized. So yes, a lot of variations in the veins, different embryology than the arteries. Rules still cannot be applied in every one of them. But there are like things that we already know, like the connections to the cavernous sinus can be have a lot of variations. Some of the cavernous sinus doesn't drain the brain at all because of its embryological background. And when it comes to transvenous embolization of the AVM, it's probably more of the the hemodynamic of each case, of the morphology of each case of the AVM. I personally, I have never done any transvenous embolization of the brain AVMs because I don't think it's going to be safer than what we are doing now. So I don't know how this thing is going to be developed in the future. It's absolutely a new concept of treatment. It has higher cure rate, but I still prefer to do a transarterial embolization combined with gamma knife is our preference of treating brain AVMs. I have no experience on transvenous.
Okay, thank you very much.
Thank you, Dr. Wismaji. Is there any question from the panelists, other panelists?
Dr. Afan?
Yes.
Thank you very much, Dr. Kitipong and Professor Ashmi, for the beautiful lecture and the cases. So I would like to ask to Dr. Kitipong, sometimes if we do embolization of the meningioma for the parasagittal meningioma, like your last case, we see that after several drops of glue, and then suddenly there is a channel open. So is it possible that actually that is it a rudimentary channel that suddenly open after several drops of the glue that we put into the tumor?
Yeah, this has been mentioned in the slide of Professor Azmi, the injection and the pressure gradient. So even though you get a very good injection, sometimes when you have the tumor is still has the flow, your contrast will be sucked into the flow of the tumor, which you don't have enough pressure to see the other openings. People say, yes, something will open and you have the connection, but it's not really open. It's always there. It doesn't open because you inject and you get another vessel instantly. It doesn't happen like that. It's always there. But depending on the injection condition, you have a wedge catheter, you inject very strong, you might be able to see everything, but it doesn't happen all the way. So yes, you have to trust what you see, but you have to be able to predict what you do not see. So that's probably the point that why we need to learn anatomy. Yeah, it's a very good point to say. So that's why I showed you the last case. I was trying to find a case like that we don't see the ophthalmic artery at the beginning, and at the end we see something. It can be more complex, like in the face, as Professor Azmi has shown in his case of juvenile angiofibroma with the embolic material in the eye, because there are, concerning the orbit, I just showed you part of it. It can be from the inferior side of the system that has the connection with the sphenopalatine arteries, very small. Sometimes you don't see with the tumor stain with other arteries in front or in the back of the picture. It's hidden between those arteries. So well, just try to inject with your microcatheter softly first and strongly to see anything. And if you reflux, anything can happen. So that's a little bit on technical side, which depends on your level of experience. But even in experienced hands, you can get complications due through these channels that you cannot see, but they don't open instantly when you inject. But well, it's being visualized after some parts have been blocked, and the only outlet is that channel that we say that it's open. That's a very important point. Yeah, thank you for the question.
Is it enough, Dr. Iwan?
Yes, I think so.
Maybe Dr. Setiawidi, do you have any question? Yeah, you need to still unmute your phone, Dr. Setiawidi.
Okay, thank you. Thank you. I enjoy both lecture, and we all understand the very importance how we have to understand anatomy before we do anything, and there is an insight for me that while anastomosis from external to internal is very important for us while doing surgery, it is an advantage that we have anastomosis, right? So doing surgery, if we have anastomosis, we can sacrifice safely. So understanding this anatomy is very important while doing surgery. But the second is that while doing endovascular surgery, we also have to understand anatomy very importantly because it have connection. So I think, yeah, this is my opinion. Both are very important. The other side we can sacrifice because anastomosis is an advantage for us, while in the vascular we have to be very careful because there is anastomosis. But yeah, it's my opinion is like that. What about? Please comment about this. Thank you. Yeah. Mm-hmm. Yeah.
Professor Army, maybe
yes.
you have any comment regarding to understanding anatomy?
Yes.
Yeah.
Is that right or?
Okay.
Yes, yes, correct, Dr. Willy, because anatomy is important. As we mentioned just now, this anastomosis we cannot see during the procedure, only when we have progressive injection material. Then another thing that the material that we choose also, they can penetrate to very small, tiny vessel, even can go to up the vessel. Sometimes even if we take all the specific precaution, the specific measure, the complication like cranial palsy can happen. So this is very important. Is actually before the procedure, talking to the patient, explain to the patient what is the possible risk so that they can understand better. If rather than say that it's endovascular is very safe for you, no, it's not. We can't predict because every patient is very different. That's just my comment.
Yes, yes, I agree with that.
Yeah, I think your comment is very, very excellent because I used to put in some of my slides the things that you have said, because the anastomosis can be our friend, as we can occlude the ophthalmic artery from the ICA without any consequence in many occasions because of the anastomosis. But at the same time, the anastomosis can become our enemy when we inject something and it goes through those channels and it goes to another system that we don't want the particles to enter. So they can be our friends, they can be our enemies. Yes, it's the same concept, but different aspect.
Yes.
Thank you very much for the Truidi and all the answer.
Thank you. This is my comment. Please.
Yes, we have a question from the attendee. The question is, in order to avoid complication due to unseen anastomosis of ECA to ICA, should we promote consistent use small coil instead of particle-based or liquid-based embolism? When the selective embolization seem high risk, is there any role or benefit of ECA ligation? Maybe the first one. Maybe in the future there will be more small coil instead of a particle based on liquid embolism? Maybe Prof. Azmi or Dr. Kitipong, in order to.
I think when we dealing with vascular malformation like dural fistula, we are dealing with very small micro channel. So it's quite impossible, quite difficult to get achieve cure for this kind of the cases, because there's multiple channel and multiple feeders. Even though the principle you still go to the usually single draining vein. If we can safely approach, enter the draining vein, and maybe you can put a coil. But if most of the cases is very tough. So I think for the past 10 years, when this active alcohol is already in the market, that solve a lot of problem treatment of intracranial dural fistula. We have techniques to prevent unnecessary embolization, preserving the vein. Maybe like we have like balloon just now. Also sometimes we protect the labia, we put the other smaller balloon. So the technique, the understanding, the behavior of the material and your experience is also very important. So in terms of the treatment, you must understand the disease process, flow of the fistula of vascular malformation, and also whether there is any dangerous possible animosity around the area that you must understand too. Okay.
Maybe from Kitipong. Okay. I think maybe from other panelists, if there are any questions. Okay.
Can I have a question?
Kitipong share some screen. Maybe you want to share some.
To add to Dr. Azmi's comment, so the particles or other material, larger particles, smaller particles, is probably not only that, it's also the technique and where the catheter is. But in general, I think you can see my screen now. In general, anything you put proximal, so if you have a lesion here, anything you do proximal, if you are too proximal and you put particles, it will enter the other arteries like this, okay? So you try to use larger particle to be safe. Yeah, it can be safer, but you cannot predict how large this channel is. Sometimes they say it's 150 microns, but it can be even larger than that. I have shown you the connections, okay? So you want to use, go closer to put anything there. The closer, the safer, of course. But if you reflux, you can enter anything, okay? And there's still connections, like very small ones over here. And if you put coils, I don't know, it's not working properly. If you put coils, it would be too proximal, you'll be safe. So it's either you're safer or you're less efficient, okay? I don't know, the slides are not working very well. Anyway, just to add on to that.
Yes, I think it's explaining a lot. Okay, maybe from other panelists, is there any question?
I have a question to Dr. Kitipong.
Yes.
Okay.
Yes, you can.
I'm listening.
Yeah, thank you. In the presentations of Dr. Kitipong and Prof. Asli is very nice. I have several questions. One question is, if in one condition we have suspected, if there is any remnant of embryological artery, will it always be between the ICA to vertebrobasilar system, or it can also be between ECA to vertebrobasilar? And will it always be visible during the angio?
Mm-hmm. So the embryological remnant, what do you mean by that? So it means in general, the connections that we had when we were like a fetus, it was the main supply to that system. A good example is a trigeminal artery. is one of the good example that we see quite often. It goes away when become a like a baby. It goes away when we are born, and but the other. So these are the embryological connections. So most of them are like the ICA to vertebral artery axis anastomosis. For the external carotid artery system, I didn't have time to show you much, but actually the branches that we see from the middle meningeal arteries are used to be originally from the internal carotid artery as the stapedial system. So these are the pharyngeal arteries that we were like fish before. We have the pharyngeal branches for the gills to breathe, and when we come more developed as mammals, these vessels become involved in the development of this external carotid artery system and the internal carotid artery system. So yes, in the beginning they were connected and they got separated. There's the shift in the territories to end up with the final disposition. And we don't really see this in normal objects, but if we have the agenesis of the internal carotid artery, the external carotid artery branches, this embryological anastomosis can take over the internal carotid artery itself, becomes like the aberrant ICA, and so on. Even in pigs, not in humans, in pigs, the ascending pharyngeal artery will become the what we call the internal carotid artery in humans. So it has a very high connection. And the most interesting is that we can have agenesis of the internal carotid artery system. We can have agenesis. You don't need the internal carotid artery to be successful in the development. But there has never been any agenesis of the external carotid artery system. Probably if you have something wrong with the development over there, that that baby will not survive or something. It's very serious complication if you have the something wrong with the external carotid artery system. Yes, so there are connections, there are developments related to one another, and the external carotid artery can take over the internal carotid artery system, but not vice versa.
Okay. So it will always be visible if there is any.
Visibility, probably the most ones that we see will be around the cavernous sinus. We have seen that in a few pictures in the past presentation. Yes, it would be there, but not in all cases. In about 20-30% of the cases, we have like direct connection, large or small. It depends on the patient. It's not always there, but you have to kind of like predict that it might be there when you do something.
I mean, in this case, it's not the dangerous anastomosis, but I learned that from others that dangerous anastomosis not always seen. But how about embryonic arteries, embryonic? If in the remnant of embryological artery, if there is any, will always be seen. Will it always be seen? Is it is it the same like dangerous anastomosis, or it will be different? If there is any, we will see it. We will not miss it.
It's very difficult because there are many situations that can apply to your question. Like I've shown you the occipital artery connection to the vertebral artery. That can be considered one of the embryological, connections. And sometimes you see it, sometimes you don't see it. It depends, as with other connections that we have talked about. It depends on the injection conditions and everything. So it's probably not always there for you to see, even though it's there.
Okay, thank you.
Thank you, Dr. Nia. The other panelists, maybe? Or I can switch to another. Dr. Lutfi, but there's an answer, but already. Okay. There's a question from Dr. Harsan, already answered by Kitipong. Maybe Kitipong can explain. The question is, in the case of petroclival meningioma, how to cannulate ascending pharyngeal artery and MHT.
I think Professor Azmi can answer that better than me. He's shown the cases. Well, the clival artery, the meningeal hypophyseal trunk, usually is, very tortuous, very small curves. You cannot pass the catheter very distally. So I would do probably the same thing with Dr. Azmi. We need a balloon to control the catheter, and I would not be too aggressive in embolizing, trying to penetrate to everything. But to be honest, if you have a leak of a like glue or something, one drop in the ICA, it depends on where it goes. Usually it's not a big disaster, but we don't intentionally let anything go over there. So it's a high risk skull base. Parasagittal meningioma, I don't think we need to embolize everything. Just between you and me, but this is online on the YouTube. It's for training also, okay? For skull base, these are serious things. We have all the connections from the ICA, from the vertebral arteries, all those cranial nerves. Anything wrong can happen very easily at the skull base. But for hypervascular skull base lesions, the surgeons will need the embolization than they need for the parasagittal ones. And we have more risk as interventionists too. So it's a balance between if we are going to take the risk or the surgeons will take the risk for us. So I usually do my embolization with parasagittal meningiomas under local anesthesia. I think it's sufficient. But for skull base lesions, I will try to make the patient still with general anesthesia to be able to see the pictures more nicely. It's not the specific answer for this, but in general.
Yeah, in general,
risk, yeah.
For like pre-op embolization meningioma, I only do the extracranial component. Extracranial is a very big, very high risk. My friend surgeon can control the bleeding. I just our service just to get additional support during the surgery. So if we see the digest anastomosis, maybe we don't need to perform the embolization too, or you can use maybe coil rather than particles. Especially when you see the meningo-ophthalmic, you don't see any ICA and ophthalmic artery during ICA. Right? So better don't use particle because that anastomosis can open when we gradually inject the material.
Thank you very much. There's a question from Dr. Luffy to Prof. Azmi regarding other cases. When do you combine embolization between gamma for AVM? You already answered here, but maybe you can explain again.
For AVM treatment, we must discuss with our MDT team whether which modality is very good for the patient, either radiosurgery only, embolization, and also in combination. But if like maybe superficially can do surgery embolization. If we don't have specific answer where it's very big AVM, we can reduce the AVM size, then followed by radiosurgery.
How about in your center, Kitipong?
The treatment of the AVM will depend on very strongly on the preference of the team. If there's a surgeon who is very, very good at operating, I would maybe send him to have the AVM removal. But as you've seen in Aruba study, I don't really think Aruba is the real story. It has too high the risk for endovascular treatment, like 20% risk. So if you allow me to have 20% risk to treat a brain AVM, I think I can do anything, transvenous, trans anything. But if you try to lower your risk to like a few percent, that's gonna be another story. So we need to combine the advantages of each strategy to another one. For exceptionally like special cases like a bleeding with a bleed or something, we will remove the AVM. But for those that we don't need to remove the hematoma, I prefer to wait. I had a few cases that bled during the what we call latency period after gamma knife. I felt sorry for the patients, but still we believe that in the long run we have less complications than doing a too aggressive endovascular treatment, especially in very low grade AVMs located very distally. Sometimes to navigate a catheter, a balloon catheter or transvenous, it's probably more simple to just remove the thing or using other means. So it's not a race between endovascular culture, between to the surgery or to the gamma knife people. I think we need to cooperate. That's probably the thing that we need to do. They are probably the pioneers that do acrobatic embolizations, but I don't think I'm one of those pioneers that need to do those new techniques and everything. I would observe for a while for people to do those type of new techniques to see how it works, and maybe I will try to do the same thing after a few years, but I don't really think I need to be the pioneer to try everything new. So transvenous is something I still feel very reluctant to do. So we are doing what we are doing more than 10 years ago, embolization and gamma knife, the combination. We do embolization first and gamma knife later on.
Good, thank you for the answer. Is there any more question from the panelists?
Maybe just a
bit. Okay, Dr. Nurullah.
Yeah, maybe just a bit. I think first of all, thank you for a very informative presentation. So, like in conclusion, you make selective angiogram, especially to the vessels that you mentioned above, the MMA, the falx for sure, the orbit for the vice versa flow from the orbit to MMA and MMA to the orbit, and also to the posterior fossa. And for that, very safe for us, if it's possible, we use a selective angiogram, meaning a more micro and detailed one to have the visual of it, right? And then for the occipital portion, the one that I didn't get is for the jugular foramen, which is the smaller and connective to the lower cranial nerve. I didn't get the presentation. What is the marker for us to be careful in that part? That's for
it's difficult to answer precisely where the nerve supply comes from, but anything distal to the jugular foramen, it's pure dural branch. Anything distal to that, you're safe. Okay.
So just make sure that you are over the distal for whatever what you're going to embolize.
Yes. But in exceptional cases, these posterior fossa dural arteries can have connections to the pica. In exceptional cases, it's difficult to explain, but in exceptional cases. But in general, you can assume if you have an onyx, you wedge and you inject into everything, I think you can enter anywhere. So not over-wedged, not over-injecting anything, know what you want to do, know the goal of your treatment, how much you should put your embolic materials. That should help you being more safe.
Because getting distal is mostly a problem.
Yeah, that's one of the technical thing. Yeah.
Okay. And then for the ascending pharyngeal artery, just check for whether you're not connecting to the vertebral artery, right? So from the posterior portion especially.
Yeah, the ascending pharyngeal artery is more complex. The branches are very small. It can connect to the ipsilateral vertebral artery, and it also can connect to the contralateral vertebral artery also. So that's in the neuromeningeal branch system. And you still have the other branches that connects to the middle cranial fossa. It connects also to the system of the external carotid artery. Even though you're in the pharyngeal branches, you can have the potential to enter the Vidian artery. As you've seen, it was the main supply of the juvenile angiofibroma. So if you inject too much, into these pharyngeal branches of the ascending pharyngeal artery system, you can enter the ICA through that channel. Yes, so it's a very tricky, if you want to embolize through the anterior carotid artery, you will be very nervous about that. You should feel the same thing when you're in the ascending pharyngeal artery system. I don't say you cannot. There's no dangerous place, but you have to know. Pierre Lejeunesse used to say that even though it's a dangerous road to drive, if you drive carefully, you can drive. Okay.
Okay. Now for
if you drive widely in a safe road, you can get into an accident anyway. So it depends on how you drive. And if you are a good driver, you can drive maybe anywhere.
And the most embolize that you use for embolizations, like for tumor, could you like, in overall, what is the embolant that mostly used for tumor? What is most used for AVM? Like most convenient.
Yeah, that's another difficult for AVFs, for dural AVFs. It always should be embolic materials, no particles, no coils, because it won't give the cure to the treatment. Coils at the proximal site of a dural arteriovenous fistula feeder, that's the worst thing you can do. If you cannot send if you not pass your catheter distally enough to embolize using embolic materials, better not to do anything and send it to someone else. You'll create more problems to the patient, to the patients. But for so that's for tumors. Some people would prefer to use particles because they say it's safer. For my preference, I think I'm not the majority. The majority of the people probably use particles. I don't know if Dr. Azumi will agree with me. I prefer to use embolic materials. It penetrates more. It has more potential to cross the anastomosis, more dangerous. But the advantage you can get with the liquid embolic materials is that you can see where it's going. I feel it's safer when I see where it's going. For the particles, sometimes you reflux a little bit, but you don't see everything. It's just a personal preference. I don't think this will apply to everything. Sometimes I use particles too. It depends on the flow and everything. So you probably need to learn how to use both tools. I don't have one single best answer to this very difficult but practical question. Maybe Dr. Azumi can add something to this.
Yeah, for me, for pre-op embolization when meningioma, I like to use diluted glue 35%. If I think there is anastomosis, because I just can use particle.
Sorry,
and also
diluted glue, how many percent?
25%. Because I just need to reduce the vascularity, not complete penetration of the tumor. Thank you, Afan. Thank you, Ketipong. Thank you, everybody. I need to leave now because I have another 11
meeting.
Thank you very much.
Yeah.
Thank you.
Thank you. It was nice meeting you.
Nice meeting you too.
Thank you, Professor.
Yes, we have.
Thank you.
We have 5 minutes more to 10 o'clock. If there's any more question from the panelists,
I have more question. One
Yes.
more question, Dr. Afan.
Yeah.
Okay. This is very nice, very good discussion. So let me give me or trick or tips when I'm doing embolization that we sure that we see the dangerous anastomosis. There is happen dangerous anastomosis, but we must doing embolization. So give me or tips to make embolization more safe, maybe by technique or by choosing viscosity or the size of material. Would you please to answer, Dr. Ketipong? Yeah.
Yeah, we finished by a very difficult question, which brings us to the maybe next discussion. Maybe there's probably no absolute safe way to avoid a problem. People say if you use larger particles, you cannot enter the nerve vasorum, so you cannot damage the cranial nerves. That is most of the time very true. The more penetration you get, like if you try to really destroy a nerve by embolization intentionally, what should you use? Okay, so we put it in the other way. The best material should be onyx. It penetrates very well, so it will enter the nerve vasorum uh, to damage permanently the nerve. But if you use particles and you damage part of the supply of the facial nerve, uh, you will have only like temporarily the facial palsy. So that's the how to take care of the cranial nerve palsy. Use larger, less penetrating material. That's probably very true to when you want to have more safety with the cranial nerves. But for the anastomosis to entering other systems, the channels, it depends on the anatomy of the patient. For large channels, probably you will see like on your DSA, if you know where they are and you know where to look for, and you have the proper technique of injection, I don't think you will miss anything larger than 200 microns on angio if you have a proper decent angio machine. But anything smaller than that, probably you will miss it. So if you have a good knowledge on anatomy, you look very well in your DSM images, you use more than like 250 micron size or 300, 500 something, I think you will be safe almost 99% of the time. Or if you run into trouble, you can go back and look at the images. There will be an answer to that complication. If you look back, oh, there's connection that I missed, something like that. So yes, larger particles, safer, but maybe a little bit less effective. But if you want to like preoperative meningioma embolization, you don't have to be perfect. That's not the only treatment for the meningioma. It will be surgically removed. So you only need to reduce the blood supply to help the surgeons to operate easier. So you don't have to be perfect. So particles will be very fine in most of the cases, larger particles. But for dural arteriovenous fistula, you have to kill it because most of the time the endovascular treatment is the only choice that the patient has. So these will have to deal with embolic materials. So the point is, yes, you need to have the technique, proper technique to bring your catheter as close as possible to the fistula. It's like aiming a gun. You are close to the target. You can be a bad shooter, but you will hit the target. If you're far from the target, there's more chance that you will miss the target. So the position of the catheter, the position where you are, the anatomy, and the material. So it's probably the combinations of these three things that will make the perfect match and make you safe and efficient for the procedure.
Thank you very much.
Thank you very much for all the panelists and attendee. We already reached the end of the webinar, but maybe I want to have some advice or message from Kitipong. We have a student here, we have a resident here, we have a neurointerventionist here. We starting from understanding. I learned a lot because when I meet you in the first Planet course, and I really understand that neuroanatomy is much more important than anything, and your last slide is very important. Maybe one last message and advice from you.
Yeah, thank you to give me the opportunity to say this. So learning anatomy we all know that it's important, but when you open up an anatomy book, you fall asleep. It's too difficult to learn, you know. It's like you try to learn German or French or Japanese by yourself. It's quite boring. So I have been trying to teach people anatomy, trying to make it more simple. Pierre Lejeune was a great teacher, but a lot of things that he has told us was so difficult to absorb, you know. It was so high level. So what I have been doing recently, I'm creating illustrations to put things in more simple ways to make people anything that we have been learning in the past 10 years. I want to make it like 1 or 2 years that you can catch. And I think the best way that you can do this is you have to try to draw yourself. So the illustrations I've given out to you, you can draw on that. You can make copies of it, draw on it, look at the angiograms, match that with the picture, make your own drawings. It doesn't have to be a very nice drawing, but yes, as any language, it has to be practiced. So if you inject an internal carotid artery, you have an aneurysm at the MCA, don't look only at the aneurysm. Look at the ophthalmic artery, look at the branches of the ICA. You can see variations. 10 of maybe you have 100 aneurysms, you probably have some 10 or 20 anatomical variations that you can pick up on the angiograms. Also the venous phase. People don't look very much in the venous phase in normal subjects, but anything on the angiograms, look at it and it will teach you a lot. Any vessels you recognize or you don't recognize, just go back to the books and everything. You can send me emails. I see some vessels I never seen before. You can send to Afan, and yeah, it's talking to people, talking to your colleagues about anatomy. That will be a good way to practice.
Yes, thank you very much, Dr. Kitipong, Jack. Thank you very much. Now we're in the end of the webinar. Very honored for me to become your moderator. I hope this is useful and good for your understanding about neuroanatomy and your using for your clinical use for your patient, of course. Thank you very much for today. Good morning. Bye. See. Have a nice weekend. Thank you.
Thank you. Thank you. It was nice to see you. Bye-bye.
Bye.
Thank you very much. Bye-bye.
Thank you. Assalamualaikum.
Waalaikumsalam. Makasih Mas. Makasih Dr. Widi. Ya, hilang semua dulu. Ya,